Let's get started. Dr. Hargarten, let me introduce you. He currently serves as the director of the Comprehensive Injury Center and as professor of emergency medicine at the Medical College of Wisconsin. He's been practicing emergency medicine for over 20 years and has been active in injury control for the last 16. His full biography is available in the meeting materials, and he'll begin by answering the question, why do health systems have a role? Please come forward. Thank you very much.
You're gonna put me. Do you have a visitor pointer?
Yes. It's here. So
That's the pointer.
I'm sure that Melissa will be keeping score to make sure that I haven't forgotten to say anything. But
I am not Terry Richmond.
you wish you were. All right.
So this is the opposite, and that's the pointer. Great. Thank you. Thank you very much. It's indeed an honor and pleasure to be here today to make some opening remarks and hopefully persuasive remarks about how health systems can be engaged in this significant burden. I do want to highlight, at least recognize the leadership of the Academy, the leadership of Kaiser Permanente and the American Hospital Association for this historic workshop. This is very, very exciting, and I really look forward to the 2 days of discussions. There has been repeated references to the rapidity of this workshop coming together, but as an emergency physician and my colleagues in emergency medicine in the audience, this is probably routine type of movement since we operate in minutes and hours in the emergency department setting. But again, really appreciate the leadership of Melissa and Rose in getting this together and working with George and others on the planning committee. I have no disclosures to present and wish to begin to talk about this and frame this issue in a way that pulls in healthcare systems, pulls in healthcare system leaders to talk about this in a meaningful way. Not sure if this is advancing. So I'm not sure.
Use the arrow keys maybe on the keyboard.
Sorry?
Just use the arrow keys.
Yeah, I might as well, since I'm here. So today I want to frame gun violence as a complex biopsychosocial disease. By framing it in a way that pulls us in, we better understand what this burden really is to our systems, define our roles for gun violence prevention as healthcare system leaders of civil society, and seeking to advance, in this case, injury science for injury prevention and control. This is all about science, has been referenced with our opening remarks, and I think it's important for us to embed this discussion in science and advance it with scientific understanding and identify research issues as they come along. Our patients are presenting to healthcare systems in crisis. They present to the emergency department, where many of us live, and clinically treat patients with parasuicides. We don't know what the subtle presentations are of at-risk patients presenting to outpatient departments. To those patients who are diagnosed with cancer, who then leave despondent and are at risk of committing suicide upon discharge from the hospital. Assaults are presenting itself continuously to the emergency departments. Are those at-risk patients of committing assaults or being a victim of assault presenting to the outpatient departments? What are those numbers? What is that burden that we can get better at screening, that we really want to do a better job as healthcare systems to prevent the suicide, to prevent a serious assault or homicide? And those, again, at-risk patients being treated and discharged who are at risk of transforming themselves from a patient who experienced a gunshot wound to an individual who discharges that energy and commits a homicide or a significant injury to somebody else. Among hospital-treated non-fatal injuries, near drownings, self-harm, and firearm-related violence are the most costly. This was a recent analysis conducted and published this year to look at the incidence and costs of injuries to children and adults in the United States. So we've talked about the burden in terms of lives, but it's also a costly injury, a costly problem for healthcare systems and for our communities. In a recent publication, again from MMWR on the National Violent Death Reporting Systems of 27 states, the suicide antecedents include current mental health problems, physical health problems, substance abuse, intimate partner, and recent crises. All of those are patients coming to healthcare systems in varying degrees of crisis. We need to do and have an opportunity to do a better job of identifying and better identifying those potential victims and screen them appropriately. And this is what this workshop is intended to focus on, is how can we do a better job as healthcare systems to affect this major problem. And homicide antecedents in that same MMWR with assault, sexual assault, rape, arguments or conflict, a physical fight between two people, one of those people are presenting to the emergency department for care. Drug involvement, substance abuse problems other than alcohol abuse, and intimate partner violence. Again, these patients are presenting to our healthcare systems on a daily basis. So if you take a lot of all those antecedents and sum them up in this list that, again, came from MMWR, you can see how healthcare systems can play a significant emerging role and more effective role in identifying patients at risk, identifying protective factors, and do a better job of affecting populations who may be at risk for going on to a homicide or suicide event. Almost half of female homicides were related to intimate partner violence. Tell the story of when I started as faculty member in 1989, old enough to know some of these matters in emergency medicine. 1989, the resident was dutifully reporting the injuries to the woman who had facial injuries, contusions, x-rays were negative. I said, that's a very good summary. What happened? She said, I don't want to know. 1989. And we need to do a better job and have had systems improvement with other systems in place, such as JACO, to help us be more sensitive about the proper screening of patients and what are we going to do once we screen for those patients. Apologize for this not coming up properly, but this is the JACO admonishment for the systems to take care of patients who are presenting with intimate partner violence. I'm not sure why this is not coming up, but this is the original language that appeared, at least that's what I found in looking this up, because I was wondering when JACO came in and started to intervene on this very particular subject. Let me then take a moment now to, while presenting this the number of patients that are coming to our healthcare systems, to start to describe and frame gun violence as a complex biopsychosocial disease burden. And we want to start with the biology of this disease and assume that we want to make sure that we're all on the same platform for describing this complex disease. This is a classic entrance wound of a bullet entering into a patient. I submit to you that is a lead infiltrate. It's not Staphylococcus, it's not Klebsiella, it's lead. And there's a transmission of energy from that bullet. Remember your physics. Kinetic energy equals 1/2 mv squared. These are the viruses, the bacteria that are penetrating our patients and imparting the kinetic energy that disrupts tissues. This is a particular one. It's a hollow point bullet that has razor sharp talons that inflicts additional injury, additional cellular organ damage to patients. So this is a classic. The area here that's injured by the bullet is a permanent cavity formation. You can estimate the exsanguination that occurs from this bullet entering into the liver and the temporary cavity stretching that occurs while the energy is being dissipated. This is a more graphic illustration of the damage that the kinetic energy does to the liver in this autopsy finding, and expect the hemorrhage, the subsequent shock, and death of patients This is the pathophysiology, if you will. This is what we're seeing in our patients that have this kinetic energy exchange from a bullet. This is an example of that penetrating the aorta, and you can expect that patient rapidly exsanguinated. If you look at the kinetic energy exchange to the humerus, this results in lifelong disability for this individual who have undergone, I'm sure, a number of orthopedic revisions and, again, has experienced and will be experiencing a lifelong disability. It's important for us to understand this dynamic in a disease framework because by understanding it, we can take care of our patients better. When this bullet expended its energy to the femur, it fractured the bullet. Where did the energy go? Into the femur. The clinicians did not think about the fact that there's an occult fracture to the femur, and indeed we missed that fracture, and 2 weeks later it declared itself, and we did not prevent additional disability and outcome with this patient by not understanding the dynamics of this event, of this disease process. Boy, I'm really a little disappointed about how that's coming up here. I just don't understand it. But Dr. Stephen Sachs is talking about how the bullets that are entering the mandible, in this case the Las Vegas shooting, and he's talking about how this high-velocity bullet shatters the mandible like glass, and the actual injury only takes fractions of a second to occur, but it's a lifetime of rehabilitation, which speaks for primary prevention as a major thrust for this workshop, as George mentioned. This was a case that was just recently published in the New England Journal of Medicine, a case study of a 37-year-old man with a self-inflicted gunshot wound from an AR-15, showing the extensive kinetic energy-related damage to the face, including the CT scans and the reconstruction as the surgeons were planning to reconstruct this individual's devastating injuries in a way that's classically presented like other diseases presented in this format at the Massachusetts General Hospital. In addition, think about the fact that now we have an opportunity to study this disease like we do other diseases. In this article in 2013, it was talking about sepsis, and the pathophysiology of sepsis was very well described, and the last paragraph in that pathophysiology relates to how this may be similar to sterile injury, which is what a gunshot wound is. It's a sterile injury, and so alarmins are also released during sterile injuries such as trauma, giving rise to the concept that pathogenesis of multiple organ failure and sepsis is not fundamentally different from that in non-infectious critical illness. So framing this positions this in the way it ought to be, should be, can be, to help inform healthcare systems to be better at preventing this energy release. But I thought this was a real interesting comment by Dr. Armstrong in that same case study discussion. The last paragraph in this article, she states, although this discussion has been challenging and upsetting, it is essential for us to come together as healthcare providers to take on the issues raised by this case. The work we do to understand and affect the determinants of health in our communities has a greater effect on our patients than almost anything we can do once they are admitted to the ICU. This is exactly what I feel the excitement of this workshop is that we've got to do something about this upstream determinants of health, the behavioral health issues, and really do a great job of preventing these events from occurring. So if you look at, some of you may have some problems rethinking your years in second-year medical school, the pathological basis of disease, 7th edition on page 4. This is what a disease is. This is Koch's postulates. There's a cause. There's a mechanism of its development. There's structural alterations, and I've shown you a few slides on those structural alterations. And there's functional consequences. That's what a disease is. That's what Koch's work was. For injury, the etiological agent is a physical agent. In that same text, it's in chapter 9. It's kinetic energy. The exposure, the pathophysiology, occurs in less than 1/10 of a second. The bullet goes through the liver in less than 1/10 of a second. We know that because we've looked at it. the video camera, the high-speed video camera, is the microscope of this disease. There's morphological changes, and there's significant clinical outcomes, including fractures, hemorrhage, subdural hematomas, shock, and death. So by framing this, it then pulls us into where can we play our roles in making a difference in this disease. And this is really what I've described mostly as the biology of this disease. What I find it's interesting, though, in framing it in a broader way, we pull in other sectors, we pull in other professions to help us by framing it as a complex biopsychosocial disease with a social context and psychological antecedents and outcomes that affect our patients, families, and communities. I find it interesting when I was reviewing this paper recently, again published in 2018, on generating a core of outcomes for hospital-based violence intervention programs. I quote, "Hospital and community-based violence prevention programs seek to improve and measure health and socio-emotional outcomes as a benchmark for healing and recovery after a violent injury. Prioritization of these outcomes broadens the definitions of recovery to include psychosocial health and well-being." And that's an intervention. Afterwards, we need to look at the antecedents so that we can do better before the event occurs. And finally, in this paper, as they noted, the top 25 highly prioritized outcomes, it's related to psychosocial health. So I thought that's a nice connection that the hospital-based programs are already thinking about it and framing it in this biopsychosocial framework. So if we approach this and the opportunities for health systems to reduce gun violence, where on the right-hand side is the disease framing, the disease framework of the agent, vector, environment, our opportunities are with our host, the high-risk patient, the 20-year-old male, the 45-year-old female, across emergency departments, intensive care units, outpatient departments, and framing primary, secondary, and tertiary prevention like we do for other diseases. And in this case, primary prevention holds the most opportunity for us as healthcare systems to be more effective in preventing this disease process from unfolding. So our primary prevention challenge is behavioral health screenings across all sectors of the system, ACE assessments, social determinants. The secondary prevention needs to be strengthened and broadened for the caring of patients across the system. In trauma centers, there's about 7 or 8 that have been identified that have clinical psychologists embedded in a level 1 trauma center, alongside the surgeons managing patients who have been injured from a variety of means, including gunshot wounds, to better take care of those behavioral health issues that are emerging or were antecedents prior to their coming and prior to their being injured. And of course, tertiary prevention and the long-term disabilities that are with patients who are wounded or otherwise injured by other mechanisms that are violent related. So this is a framework for us to understand where healthcare systems can play an effective role by focusing on patients as we do for other disease processes. So the lived experience does matter. That childhood trauma history does matter, predicts different biological pathways to post-traumatic stress, and it is a primary prevention strategy deserving more research, deserving more attention. The MAPIT approach that is being employed in our campus is a multi-tier approach to psychological intervention after traumatic injury. Secondary prevention is a secondary prevention strategy. If we look at this exposure to injury, to trauma, and look at the community violence, racial, ethnic issues, and discrimination and socioeconomic status, and there's an acute injury event, you look at the health behaviors, sleep disturbances, substance abuse, biological responses, the allopathic load, gene expression, all being investigated like we would do in other disease processes. And the effect is we want good outcomes with our patients. We want reduced challenges with post-traumatic stress. So this is just one example of many research opportunities that we can have to impact this process that is endangering our patients and affecting our communities. The case for preventing gun violence is really one that's unique to gun violence. The highest case fatality ratio for suicide methodology is a firearm releasing that energy affecting these patients, and it's got the highest case fatality ratio. The highest case fatality ratio for homicide methodology is firearm related. So the case for primary prevention is where we can play the most effective role because, as noted, the exposure to the kinetic energy is so brief, there's no opportunities for acute intervention during that moment of energy release. It's too late. It's over. We pick up the pieces in trauma centers with pediatric trauma surgeons and others who effectively stop the bleeding and biologically treat this patient, but we've got other opportunities to do a better job. So broadening the biomedical model to a psychosocial model, it strengthens the care of our patients. I was talking to a neuropsychologist about how surgeons are now selecting their patients based on their behavioral social determinants so that because their outcomes are different if they do a hip operation and so forth. So it's starting to permeate the healthcare systems that this approach strengthens our care. It lowers the cost of care, it improves quality of life, and it allows us to focus our strategies aimed at prevention, and in this case, primary prevention. Perhaps our readmission rates are reduced because we're better at attending to the behavioral issues that affect patients in the way they seek care. And ultimately, we have healthier and safer communities. So the utility of framing gun violence as this complex disease process, it allows us to be science-driven. Just like those New England Journal of articles, it's science-driven. It's a sterile injury with complex pre- and post-psychosocial elements. It pulls us in as healthcare system leaders. It informs and focuses the management of patients. And it prioritizes primary prevention because of the high case fatality ratios. And it offers us a paradigm shift, and again, recognizing the leadership of Kaiser Permanente, a paradigm shift for research support, because this is the disease of the modern society of the 21st century, just like the National Academy of Sciences report over 50 years ago, in 1966, which identified injury as the disease of modern society. This was, when I found this out, it was like, this is a very, very important historical leadership change that has taken place in our country. And yes, I will quote you. Going forward, we will study interventions to prevent gun injuries the same way we study cancer, just like we do with diseases, heart disease and other leading causes of preventable death in America. When I saw this quote, this is what this is all about. The best-in-class preventive and specialized care that Kaiser Permanente provides is accomplished in part by using rigorous research without bias to determine which strategies are effective. This is, I think, the basis, again, of our science-driven agenda here at this workshop over the next 2 days. But going back a little, historically, 1979, quoting Francis Moore, and I've taken liberty with his quote, responsibilities to physicians and healthcare system leaders. Internal medicine and pediatrics have taken progressively wider views in their areas of social responsibility, the one reaching deeply into physiology and biochemistry, and the other branching out to the field of genetics and prenatal diagnosis. For the study of injury, surgery, and I pull in our colleagues in emergency medicine, pediatrics, and healthcare systems, must likewise broaden their focus to include social, environmental, political disciplines that have not formerly been considered a concern of the physician, nurses, and other leaders. If physicians and nurses, psychologists, social workers, and other members of the healthcare team fail to broaden their scope and social vision, their future will be stunted and our understanding of injury will be faulty. This is where we're at 40 years later in this historic workshop. So advancing injury science and healthcare systems for improved outcomes. I was in my dermatology clinic for a check on my skin. I'm one of those older adults who needs to be doing this, and the first thing the person asked me, have you fallen in the last 30 days? I'm thinking, why are you asking me this question? Of course she's asking me this question because it's expected of healthcare systems to be involved in falls prevention, suicide prevention. As I mentioned, domestic violence prevention, as opposed to 1989 when the resident didn't want to know what was going on with their patients. So things have changed, and George made reference to the other ways in which healthcare systems have made significant progress in other disease processes. Tetanus prevention, at-risk alcohol use and abuse, and now gun violence prevention. So we're timely in this effort, and this workshop, again, has historic elements. This is the screen that a nurse has in front of her at Froedtert Hospital, where I've practiced for many years. Look at those screening processes. And yet the training of that nurse, and I asked one of the nurses, did you get any training about appropriate assessment of domestic violence risk? Nope, no training whatsoever. And we need to do a better job of knowing how to screen effectively in these situations so that we're more effective in determining the outcomes of our patients. Boy, I don't know why this has happened. Now I can't even quote Albert Einstein. Jeez. Well, first of all, we've got to change our process of thinking. It cannot be changed without changing our thinking. So, but I guess now I can quote myself. We must move away from political and social debates to constructive discussions to advance complex biopsychosocial disease management and prevention, implementing healthcare and public health strategies, supporting research all along the way, just like we do with other disease processes. Perhaps people can be convinced that prevention, properly understood, should count for something happening, something interesting too. I don't often quote George Will, but he was describing Cal Ripken, the shortstop, because his playing and positioning, as we're seeing in the playoffs, moves, he prevents a ball from leaving the infield. It's supposed to be exciting. For those of you in baseball, it's very exciting stuff. And for us in Milwaukee, very, very exciting stuff. But it's important for us to realize that prevention is important, and it does count for something. And it counts for something for healthcare systems to be effective. So I know George and I share some history, but we've come a long ways as healthcare providers and health systems in some of these matters. It wasn't too long ago when I was a medical student in 1972 when I walked into the patient room with the family practice doctor who sat down to begin interviewing the patient, and he proceeded to light up his Camel in front of the patient, 1972. So lots of things have changed. I hope that this brief introduction and brief discussion that I've had a chance and honor to present pulls us in together to be more effective. And as healthcare systems, it's right in line with what we've done with other disease processes and other injury-related events that we're trying to do a better job in falls prevention and now, in this case, gun violence prevention. So thank you very much for this opportunity.
Thank you very much, Steve. That's just terrific. Your reference to getting your skin looked at and falls. I just traded in my first generation Apple Watch for a new one, and I haven't yet tested the fall detection algorithm, but I hope I don't need to today as I stumble around on the stage here. You also have been very effective in terms of staying within your time frame, so I really appreciate that.